65% of all female cancers are typically diagnosed late.
You know, a lot of patients feel that cancer causes pain. Actually, it doesn't until it's a very advanced stage, but majority of the time, especially ovarian cancers, they are painless.
I had a patient last week, came in and she had an ovarian mass. She didn't know, she had no pain.
In practical terms, I think just be yourself, just to be normal. Talk to patients as if they don't have cancer compared to be strong.
Dr. Mafwa Nik Izamuddin specializes in clinical oncology and has been practicing for more than 10 years. She's a leading specialist focusing on various oncology interventions in radiosurgery and advanced radiotherapy. Dr. Jibran Gay Hashim specializes in gynecology with a further specialization in gynaecology. He has over 10 years of experience understanding the science on women's reproductive health and the cancers of the female reproductive system. Together, they break down what cancer really looks like in women, the early signs most people miss, and simple steps you can take to reduce your risk. This is a conversation every woman needs to hear. Cancer is a well-known leading cause of death. This is certainly the case here in Malaysia, and according to the Malaysian National Cancer Registry report, the number of deaths by cancer is expected to double by 2040. Now, unfairly at the same time, the risk of cancers in females is typically higher than in men. And beyond the usual cancers, a large portion of the female cancers is also driven by reproductive-related cancers, otherwise known as gynecological cancers. Welcome back to Let's Talk About, a health podcast by SJMC. My name is Leonard, and today let's talk about female cancers. Joining me today is Dr. Mafwa Izamuddin, clinical oncologist.
Thanks, Leonard, for having me. Hi, everyone.
And Dr. Jibran Gay Hashim, consultant gynaecologist.
Hi guys.
Doctors, welcome to the podcast. You know, breast cancer is still the leading cancer among women. 32.1, 32.9% of all female cases. To many people, isn't breast cancer female cancers? Is there more?
Oh yeah, definitely. We tend to forget that females also have got female reproductive organs. Women have got ovaries, women have got uteruses or wombs, women have got cervixes, which all contribute to female cancers, not just breast cancer.
Right. And why is it then these cancers, Dr. Mafwa, we talk a lot about breast cancer, clearly, but we don't talk so much about all the other gynecological cancers.
I think it's also having to do with it's easier to realize breast lumps because it's more physical, like women check themselves. And it's also easier to talk about breast cancer compared to gynecological cancers because, no one really likes talking about your periods, your bleeding.
Is it still a bit taboo?
Yeah. And I think it also has something to do with the awareness. There's so many promotions on Pinktober. Everyone wears pink in October. Not many people know that cervical cancer is actually purple.
Mm-hmm. I didn't know that.
Yeah. So I guess it's a lot of factors, but I think it's time to really bring this out to the public.
Well said. So for women listening in today we won't be talking too much about breast cancers. Instead, we're going to be focusing on some gynecological cancers. And I think that's where ovarian cancers, cervical cancers, and womb cancers come into play. I want to throw a piece of statistics here. It says that 65% of all female cancers are typically diagnosed late, at stage 3 or stage 4. When it comes to gynecological cancers, Dr. Jibran, is this what you see in your clinic as well?
Yeah, it tends to be the case, especially amongst women with ovarian cancers. I think there's an off-quoted study that says that 75% or 3/4 of women only discover they have ovarian cancer at stage 3 or stage 4.
And stage 3, stage 4 being late.
Late, yeah. There's only 4 stages, 1, 2, 3, 4. I tend to see women earlier, especially if they have womb or cervical cancer. And this tracks with this trend or this overall picture of discovering ovarian cancer is a bit later and womb and cervical a bit earlier.
Right. With breast cancers, and I know we're not talking about breast cancer, but there are clearly mammograms and things like that. For gynecological cancers, right, what is the equivalent of the mammogram?
It's a good question. Okay, so unfortunately, ovarian cancers don't have a special screening. There are things that are being developed where you can take blood and they can apparently discover if you have ovarian cancer. But this is still within the research stage. It's not mainstream yet, and it hasn't really been trialed yet. There's still talk about it, but it's still research. So ovarian cancers, unfortunately, they come in late, so they need to be examined before we actually come to a diagnosis. We do have something called HPV screening these days, and I think we'll talk about that more later. That is something that can pick up cervical cancer very early, and that is a very useful tool that we can use. Women who come to me with womb cancers usually come because of heavier than usual periods or bleeding that's very heavy or just abnormal bleeding. So no real screening tools per se for womb cancers, but we have a really, really great screening tool for cervical cancers.
Right.
Yeah.
So then the issue with, let's say ovarian cancer, for example, if there's no real screening tools, typically how would someone figure out they've got ovarian cancer and so forth?
Good question also. They come in because they usually present with very, very non-specific symptoms. They complain of things like a bloated abdomen. That means the tummy feels bloated. Maybe they've got some gas, or they feel usually their appetite has reduced somewhat. They could probably eat a whole plate of rice prior to this, and now they're eating 2-3 spoonfuls and they're saying they're feeling very full. Also very non-specific, maybe loss of weight, loss of appetite. So ovarian cancer is very sinister and very, very non-specific symptoms.
Is this what you see in your practice as
Yeah.
well? Has there been any patients like that?
Most of the time, that's how they come. Yeah.
What kind of symptoms do they come with typically?
It's usually due to a bloating or a discomfort in the tummy.
It's really very vague, isn't it?
Yeah, very
it's
vague.
very vague.
Very, very vague.
And they get very surprised that it's actually ovarian cancer, or they get very surprised that it is at this advanced stage. A lot of patients feel that cancer causes pain, but actually it doesn't until it's a very advanced stage, compressing on your other structures, you get pain. But majority of the time, especially ovarian cancers, they are painless.
Yeah. Just to budge in, I had a patient last week who actually came in because her boss said she looked as though she had put on weight. The boss said, "Hey, your tummy looks bigger than usual." And the boss asked her to go and seek treatment, and she had an ovarian mass.
Right.
So she didn't know. She had no pain, just like Dr.
How
Mahfuz
old
said.
was she, if you don't mind me asking? she
Early
young?
40s, mid 40s. Yeah.
Right.
Mm.
It sounds like 40s and above, especially given that these are late stage presentations, right? Are young women at risk, and can young women do anything about that then?
Yeah, young women are at
I
risk.
think we're seeing like a lot of younger women
Yep.
nowadays presenting with cancer. I think the most important thing is that for women to, or not just women, anyone to be aware of their changes. Like for young women who have their period every month, having bleeding in between doesn't sound right.
Yeah.
Having bleeding after sexual intercourse doesn't sound right. It's not always cancer, but it's worth checking, especially when we talk about cancer. Cancers tend to be progressive. So if it's getting worse, persistent, then I think it's something worth checking.
Right. So if women listening in today, they feel something is different, does every different thing warrant a check with the GP?
If you've lived it for a while, for example, like within 1 or 2 weeks, for example, it doesn't get better, it's worth just checking in with your GP. Perhaps it's really just gas. But then if there's something sinister, at least we pick it up.
Right. So if it's persistent, it's consistent,
Yeah.
get it checked out. If it's just gas, hey, that's not too bad.
Yeah.
Right. And beyond the GP, should they see a specialist?
I would say that, of course, when we are the first point of call as a doctor, you would then think of common things first, like patients presenting with gas, you will treat as gastritis. But if you're not getting better, or if the treatment that has been given to you doesn't improve at all, or you're getting worse, then it's worth asking for a referral.
Right. Thanks for listening in, and I hope you're enjoying the episode so far. If you find the message meaningful, share this to somebody close to you or a loved one. So we talked about symptoms and signs when you should go and see your GP or the specialist, the gynae, right? And I want to touch about cancer markers very quickly, right? Because they're all in our screening
Yeah.
tools.
Mm.
When it comes to gynecological cancers, right? Are they of any use? Are they of any merit?
Number one, we have to understand that not all cancers have a specific cancer markers. And actually cancer markers are not very specific either. So you can have all your cancer markers normal, but you can still get cancer.
Right.
And for us, generally, we don't use it to say that a patient has cancer. We use it to monitor treatment, because if we see that the cancer markers are going down, then hopefully we are on the right track. So it's not necessarily to say it's a diagnosis of cancer when you have elevated tumor markers.
So even in gynecological cancers,
Yeah.
it doesn't mean much, unfortunately.
I think patients also have to understand that tumor markers don't just go up because of cancer.
Yeah.
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 Some other conditions can cause tumor markers to go up.
Inflammation.
Yeah.
Right.
So there's a lot of heartache when patients go for a medical checkup and they find a tumor marker
And they
that's
get
elevated.
anxious about it.
And
Yeah.
they can't sleep and all that. Then turns out to be something completely different. Yeah.
But conversely, I suppose somebody could have a normal tumor marker results.
Yeah.
And then,
Yeah,
Right.
that's true. Yeah.
so in any case, when it comes to gynecological cancers, symptoms, how you're feeling persistently and getting that checked out is probably
Yeah.
more
So
important.
it's not just one tool, I guess. You have to know that to get a diagnosis of cancer, you need a lot of components to it.
So, with that all said, right, you briefly brought this up, which is HPV screening.
Okay.
To, the women listening into, for me to give advice to my female friends, to my girlfriend, to my mum, for that matter, we hear about HPV screening quite a fair bit with regards to cervical cancer.
Right.
How often should people be doing it?
So HPV screening is fairly new here. And according to our Malaysian guidelines, we should be starting HPV screening in all sexually active women starting at age 30 all the way to age 65. However, if your HPV comes out negative, the test that you do, you only have to repeat it every 5 years.
Right.
Yeah.
So every 5 years if it's negative.
Yep.
Now, in the cases where, with my mom's generation, for example, in their 60s, for example, they're not 65 yet. They've never done a HPV screening. Should they still bother?
Yeah, I would still do it. Yeah.
What happens if it's positive?
Good question. If it's positive, then the usual thing that happens is GPs or health screening centers who find a positive HPV, they tend to refer patients, or they will refer patients to the gynecologist. And from there, the gynecologist takes a look at the actual HPV result, number one. Number two, will then tend to have to examine the patient to decide whether, I have to do something or not. So HPV positive doesn't mean cancer, but it's something that you have to probably, as a patient, take a look at and see whether you really need to do anything. So I've had patients come in from the health screening side with positive HPVs. I saw them and I examined them, and turns out everything was okay. So yeah.
But if something does turn out to be concerning, and I suppose we'll talk about treatment later on, but people don't have to be scared. Is that what we're saying to people as well?
Do it.
All right. So if you've not done your HPV screening yet, go and do it. And to wrap up this session, female cancers is not just breast cancers, there's a whole host of other cancers as well. Symptoms are way more important than tests. If you feel something different persistently, go and get it checked out. Remember, having no pain doesn't mean no cancer.
All right.
So we talked about the different types of cancers among women, right? But let's talk a bit about treatment. Dr. Marfa, you spend a lot of time intervening with patients. I think when it comes to cancer treatment, there's a typical association that it's going to just be chemo. And I think with chemo, there seems to be this morbid association, a morbid sentiment that, oh gosh, it's a death sentence. Is this the case?
What I like listeners to know is that the change of the face of cancer nowadays and cancer treatment. When we know about cancer and chemo in the past, you see this image of people vomiting, losing hair, like very poor condition. But things have really changed over the last decades or so. And importantly, chemo isn't the main treatment. I think that's one thing we need to know. Because majority of the cancers, if you're aiming to cure, and especially in the early stages, the best chance of cure comes from surgery. So actually you have to have surgery for best chance of cure. And we know as we get to the earlier stages, the chance of cure is the best. The higher the stage, the higher the chance the cancer will relapse. And that's why you need the chemo on top of the surgery. So a lot of patients, some of my patients actually comes for second opinion and saying that, Doktor, kita tak nak operate. We are so worried about surgery. But they don't know if they go for surgery, they might not need chemo.
Right.
She's right. I think a lot of patients do have this misconception. And like Dr. Marfua is saying, surgery is still the mainstay of treatment, especially if it's early. Just to give you an example, I had a patient who came in for an ovarian tumor. We caught it early. Fortunately, she happens to be in that 25%. And after surgery, she didn't need any other treatment. Yeah, which is exactly what Dr. Marfua says. Need to understand that the earlier you can catch something and the earlier you can get it out, i.e. surgery, the better your chances are, and the less the need for adjuvant treatment or more treatment on top of that.
So surgery sounds like the right way to go about it, especially if you picked up the cancer at a very early stage then, right? So with the whole chemo being a death sentence, is that something specific with the late stages then?
So as I was mentioning, so in the early stages where the chance of cure is highest, you generally do not need, like for example, stage 1, very early stage 1, the chance of cure is maybe more than 90% with surgery alone. So you don't need chemo. But when you get to stage 3, of course, the chance of cure or chance of survival drops to about 40-50%. Then you need the chemo to give you an additional 20%, for example. So that's where it is actually, even in the late stages, like stage 4 ovarian cancer, if you go for surgery, removing all the tumors that children could see, that gives the highest chance of better prognosis when you do that.
Chemo really isn't the only treatment available for cancer these days. In fact, I think as we've spoken, surgery is the best way if possible, especially then if we pick it up earlier.
Yeah.
Are there any other treatments available beyond surgery, beyond chemotherapy that listeners should know today?
Okay, so when we talk about surgery, for example, surgery is something local, meaning that whatever you cut, that's the only area affected. But chemotherapy and the other therapies like immunotherapy, targeted therapies, these are what we call systemic, meaning that when you take it, it goes throughout the body. That's why chemo has a lot of side effects, because it's trying to control disease elsewhere, not just in the ovaries, not just in the endometrium or cervix, for example. So, but a lot of the things that we offer, for example, like chemotherapy, these tend to be in the advanced stages because the aim is no longer cure, because it's hard to cure when it's widespread. So it tends to be in the basically advanced stages, the palliative stages, just to control the disease. So a lot of patients, like I have patients coming in, reading all about the new advancement and say, Doctor, I want immunotherapy. But she's in the early stage.
So she doesn't need that?
She doesn't need that. Also, just to sort of like talk about chemo for a bit, I think chemo has also changed since years ago. Nowadays, we have better chemo delivery, also better medication to support chemo. The patients do not vomit as before. I have patients who go for chemo and after 1 week, they are back to work. They are still mothers picking up their children. So these are the things that I think the public or any woman should know, that, having cancer doesn't stop them from living.
Right. So even if you have cancer today, for the listeners, a bit of hope, right?
Yeah.
If best case scenario, we would love to find a method to pick it up earlier. Surgery, best case scenario. But even if with chemo today, it's not a death sentence, really, right?
Yeah.
There are new ways where chemo is administered and there are better ways to manage it as well. So I want to ask a bit more for hope in that regard, right? The new advancements specifically. Where does, some of the genetics component comes into all of this? We hear about, this individualized therapy for
Personalised
cancer.
therapy,
Personalized
yeah.
therapy, sorry.
Okay.
Where does that come in all of that?
In the past, everyone with a cancer diagnosis, we treat them the same. Everyone gets chemo. But nowadays, we know that different tumor biology behaves differently. For example, if you have some mutation, you are basically better off with targeted therapies, for example. And to understand this, you need molecular testing, or what we call next generation sequencing. So we look at your gene and detect any mutation that is present in your case, and then see whether there's a match of treatment in terms of that mutation.
And how does that treatment differ from, let's say, chemo or surgery?
It's more targeted. So generally, it just targets the cancer with limited side effects. There are side effects, but most of the time it's manageable. Some of it are actually oral therapy.
Oh, so you just take a pill.
Correct. Yeah.
Is it more effective than chemo?
It's more effective in a way if you're suitable for it,
Right.
because it's directed towards your cancer.
So from time of diagnosis, I guess my curiosity for listeners as well is there a difference if we act now or we act later? I say this because, in an Asian culture, I'm familiar with my side of the family where even a simple high cholesterol gets hidden away because it's taboo, let alone cancer.
Right.
And I've personally witnessed individuals, people with cancer diagnoses, I suppose, in a state of denial, and they hold out 6 months, year, more than that. Some unfortunately passed away later on. But from a treatment standpoint, should we tell people to not hesitate and go for treatment immediately? Is there a difference in outcomes?
Yeah, I would actually tell them, if I had the chance and it were an ideal world, I would operate on them tomorrow. In a world where money is no issue or time is not a problem, hey, let's do it tomorrow.
But what's with the urgency there, right? Because some people may want a second opinion, some people may want to do, genuinely, some of them might just be in denial, right?
All right.
But what does that urgency result in?
Okay, so the problem with cancer is this. Cancer tends to grow. It then takes over other systems, and you're talking about it not just getting bigger, but spreading to your liver, your lungs. So, a short wait is definitely possible, definitely doable, but you don't want to wait too long, 6 months, a year, because we don't know how fast this cancer grows.
You don't want to lose the window to cure, basically.
Is that window very short?
I think to get ready to accept the diagnosis and also to prepare yourself for what is ahead, I think it's fine. Like maybe 1 week or 2 weeks, even second opinion. But then not to delay it until things just get worse, because then the philosophy of treatment will be different, isn't it?
Yeah.
Yeah, it will just be for control rather than you want to get, to survive this.
Then I think also, like you mentioned earlier, then that modality of surgery, because it has spread, this surgery is now no longer an option that you have on the table. And now you're talking about control, and then this is where the oncologist comes in. Yeah.
So don't wait. The moment you've got confirmation, start understanding treatment and get it as soon as tomorrow.
Yep.
Right. So I guess last question to kind of wrap up this segment over here. Chemo clearly isn't the only option today. We know that chemo is a means to control it in some sense, but there are also new modern treatments, modern advancement beyond chemo, surgery, radiotherapy, immunotherapy, gene-specific to individualized therapies, for example. So if I know somebody who needs cancer support, right, and I'm able to bring them somewhere, how do I decide which place to go? What should I look out for if I want the best cancer care?
What's most important, and I think something that maybe the public is not aware, is that when it comes to cancer care, you need a village, basically. You need multidisciplinary teams. You go for surgery, you might need some dietitian support, for example. You then see an oncologist. You might need, after surgery, radiotherapy or chemotherapy. So it is a peace of mind when you have everything under the same roof. Also remember we talk about personalization. So molecular testing, that's also very important. So my advice is go to somewhere that's established when you have all these different components of your care. Because having cancer is hard enough. You want the best support that you can get.
Yeah, you don't want to be bouncing off different centers in different places.
True.
So look for the right center. And if there is a confirmation that somebody has cancer, don't wait, seek treatment immediately.
Yeah.
Last and perhaps not least, I want to talk about the human life behind the cancer patient, right? You know, there's a lot of information. I've personally seen this, right? A patient or a loved one going through chemotherapy, for example, and they're bombarded with things they should not do, they should eat, they should not eat. You know, I really want to demystify some of these things. And I want to ask both of you, right? Like, you guys have a mass amount of experience dealing with cancer. What are some of the weirdest or most outrageous myths you guys have heard done to patients, especially, right? And
I'll start first.
Go ahead. A lot.
I've seen patients being isolated after chemo.
Okay.
So this poor nene, you know, she's not bad. She had to go through chemo after surgery, and it's this myth about chemo being radioactive, and you can't be in the same room.
No.
So she had to go on Grab,
Oh.
different cars. But I was thinking the Grab driver will be exposed if that's the case.
We don't care about the Grab driver.
But they don't care about the Grab driver. And when they get home, she is then put in a room, separate toilets, eating alone, which is, I mean, people need to know that chemo is not radioactive. Rather than isolate them, they need support.
Yeah.
Of course, they do not need to be within the crowd or possible risk of infection, you know, people who are sick, less visitors, but definitely not isolation. So I think that's one weird thing I've seen.
Yeah, what about you, Dr. Jibran?
Diet.
Uh-huh.
All
Always
this
diet.
pantang.
Always pantang. I think it's a very Asian mindset kind of thing.
It's the first thing they will ask anyway. Like the first thing they will ask, doctor, what can I eat?
Yep.
What can't I eat? And then they get frustrated.
Yeah.
They get frustrated when we say, you can eat anything.
Yeah.
What are you looking for? Like a silver answer to...
No sugar.
Yeah. No sugar, no beef.
Yeah.
No eggs.
No carbs.
Yeah. A lot of weird stuff.
And do they have any gravity or any weightage
No,
to the reality?
unfortunately not.
Right.
And I think a lot of people quote this paper that unfortunately
Sugar
doesn't
cause-
show any
Yeah.
causation. Association, yeah, but not causation.
And
It's weak. Yeah.
and that's about sugar and cancer?
Yeah.
Right.
Got sugar and cancer. So go ahead and have anything you want.
So for the record, sugar doesn't grow cancer, it doesn't
No.
feed cancer.
No.
No. Also, cancer is very intelligent. You deprive them from sugar, they find ways to get sugar,
Mhm.
like from muscles and, you know, convert things. So, and your other cells need sugar. Like, have you survived without sugar? You can't really think, isn't it? Yeah.
I suppose because there's such a vilified persona on sugar in society, right? But to set the record clear, sugar does not feed your cancer, does not
No.
grow your cancer.
No.
But I guess then what actually matters? Because when I see individuals with cancer, people with cancer going through treatment, when they go through some of these pantangs, they really shrink,
Yep.
right?
Yep.
They atrophy.
And it's not the treatment that actually causes them to lose weight. It's actually the pantang.
So then what should be the nutrition priority or what should be the diet priority for these individuals then?
I'll go ahead first.
Yeah.
Yeah. So I think considering I do the operating part, I feel that patients really need to make sure that they have a good protein intake prior to surgery. They really need to optimize things, make sure they are as well fed, nourished as possible before going in for surgery. Because you have to understand, surgery itself is very stressful. You are going to lose a lot of muscle mass. You will be deconditioned. So obviously you want to go in as healthy as possible. The only time that I tell my patients to watch their sugar is also before surgery and immediately after surgery, only because if you have diabetes, it then complicates matters because the wound just doesn't heal as well. That's the only time I tell them, please control your sugar intake. If you're diabetic, we want your diabetes to be super optimized so that the wound heals really well. You don't develop an infection. The wound doesn't reopen. And that's the only time I really tell my patients, hey, look, sugar, gotta be careful here.
But otherwise, make sure that you're well fed.
Yeah.
Make sure you've got good enough proteins.
Yeah.
Right? Does it matter which protein where it comes from?
No, anywhere. Vegan, vegetarian, meat sources, go ahead.
Right.
Be my guest.
And during intervention then, Dr. Marfa, is there any nutritional priorities that everyone should be aware of?
No, really. Because, for example, patients go for surgery, they need to be well nourished, and they need to be well nourished after surgery for recovery. They need to be well nourished for our chemo as well. And I do say this, for patients who ask about pantang during chemo, I would say the pantang comes within yourself. For example, I have patients who were previously very, Malay oriented. They like all this nasi lauk kampung. Then they go for chemo, suddenly become a Westerner. They only eat pizzas because that's palatable to them. Or people who like spicy food and the chemo, the altered taste makes them more leaning towards bland food, for example. So it's not really pure pantang, but more because of that preferences with the changes that comes. Some patients avoid red meat or malt because of the bitter taste. So it's not like pantang, complete pantang. But
It's not a blanket.
yeah, it's an adjustment and it differs. You can give the same chemo to two different patients, same dose, different reaction, different tolerance to the chemo.
Not really pantang,
Yeah.
more like preferential.
Yes, that's right. Yeah.
So every individual going through chemo have different needs in that sense, right?
Yeah.
So, I suppose that I want to understand a bit more, and especially for many of us who are fortunate enough to not go through chemo, but we want to try and understand, right? To support people better. With chemotherapy, what are some of these changes that people go through typically? You've mentioned a few
The
things, which
common
is the
ones, yeah?
taste and all
Yeah.
that stuff.
So I guess what people need to understand is that, we give chemo, normally we talk about cycles. So they are given by cycles. So generally about 3 weeks, one cycle, meaning that you go on a 1-day treatment and then you repeat that every 3 weeks. And generally, the side effects, the most common ones, tend to occur within the first week. So predominantly, rather than pain, a lot of patients are worried about pain, it's actually tiredness. They just feel like they slept, but then wake up feeling still lethargic. So I think that's most common. And how fast patients recover from this week, it depends. So sometimes I worry about my 70-year-old, but my 40 years old are the one actually having problems recovering. So I would always say to my patient, let's look at your first cycle. Then we sort of like can gauge what are you like, because some patients, they don't have problems with vomiting, they have problems with diarrhea. Some have diarrhea, some have oral ulcers. So it's important to know that each cycle will try to improve and also support your journey.
Right. So if you are going through cancer treatments, there isn't actually a specific pantang when it comes to food, but more importantly, realize the changes and work together with your doctors to see how you can manage those symptoms a bit better. We talk about caregivers, and I want to read out something from an interview with a cancer patient. And this lady specifically indicated what not to say to a cancer patient. Now I'm going to listen out for you. It says, number 1, be strong. Take care. Rest more. Why still not better yet? Have you taken XYZ medication? To the caregiver also, why didn't you give her supplements XYZ? Make sure she's eating. Make sure she's XYZ, and so on and so forth, right? When I see certain individuals going through cancer, like I said, they get bombarded with all of this, right? How should the public, especially, we genuinely want to care, I suppose.
Yeah.
But how should we go about it?
So number 1, just wanted to tell you, I've never ever said be strong to patient. Because their strength, they're there. So I never say that. So in practical terms, I think just be yourself. Sometimes because we're very caring, we're very kind. We really act out of kindness and care. The best thing to advise caregivers or people around them is just to be normal. Yeah. Talk to patients as if they don't have cancer. Sometimes do not underestimate practical help. For example, with child minding, cooking for them, or chores, shopping, things like this really help compared to be strong.
Oh, talking about one of your questions, you were saying, are you taking supplement XYZ or something? I think that brings us back to the initial question. Like, a lot of patients tend to believe that, some supplements may help. Is there any supplements I can take?
Miracle
no,
cure?
Yeah, no lah. No such thing, unfortunately, because if these supplements existed, I would probably use them. Dr. Marfua will probably be using them, but we don't. So it doesn't work. Yeah.
Right?
Yeah.
So the pragmatic stuff is probably more important. So if we as a bystander want to support things like grocery shopping, picking up the kids from school, probably more better than giving unsolicited advice.
Just be there when the patient wants. I think, yeah.
So just to kind of wrap up this section a little bit, right? The patient's already going through a lot. It doesn't help if we impose. It certainly doesn't help any further if we enforce certain restrictions, especially nutrition. So just for the audience today, as a take-home message, right? What are some of the things that, either of you would like to have the audience remember from today's session? Maybe I can start with you first, Dr. Marfa. What would you want the audience to remember today?
To begin with, again, be aware of your changes in your body, seek help. And I think most importantly is to listen to the right person. Get help, the right path, not just anyone, not Google, because, you might get overwhelmed with the information there.
Don't trust Mr. Google, trust your doctor.
Yeah.
Dr. Jibran, yourself?
Same. I would probably say, know what is normal. Is this something that usually happens to me? If it's not, then you might want to get it checked out. Maybe you shouldn't be disregarding it because it's probably not normal.
So ignorance isn't bliss.
No,
Go
it's
and get
not.
it checked out.
And another take-home message is get yourself screened for HPV. And if you can, get yourself vaccinated. I think that will be my take-home message. Yeah.
Wonderful. Dr. Jibran, Dr. Marfa, it's been a pleasure. Thank you so much for joining in.
Thank you.